A warm welcome to Indian Association for Bronchology's Thoracoscopy certification course. As you all know, this is the last module, the 10th module. We've had a beautiful journey over last 3.5 months. We have completed 9 modules, completing the 10th module today. And we are very, very happy and proud to tell each of you all that we have had 1700 logins in each of our webinar. And in fact, some of the webinars have also crossed more than 1950 webinar logins. So thank you so much to each of you all for this such a warm, for making us just feel so good and for participating in such a nice and warm way. So we have we always save the best for the last. And therefore, the topic which was most wanted by everybody has been kept as the last topic. We are going to be talking about the role of ultrasound in thoracic diseases. And we are just so lucky that we have the best faculty from our entire country who is going to be talking about what exactly we need to know on ultrasound in thoracic diseases. So the thing is that after this webinar is over, next week we will make huge announcements about our 5 physical workshops, which are going to be held in Mumbai, Delhi, Kolkata, Bangalore, and Hyderabad. The dates will be announced, and we are most looking forward to meeting each of you all in person and doing our physical workshops where you'll get so much of hands-on and where you all will get your IIB thoracoscopy certification course completion degree and the certificate. So with this brief introduction, I'd like to now introduce our first speaker, Dr. Uma Devraj. So Dr. Uma requires no introduction whatsoever. We all know she's a professor, senior consultant at St. John's Hospital, Bangalore. When we talk about ultrasound in lungs, she has been one of the pioneers. She has started doing ultrasound for lungs and for pleura even before we knew that ultrasound was so useful. A fantastic teacher, a great academician, 46 publications, 4 textbook chapters, and she is a part of every national conference which is about ultrasound. And most importantly, she's a very, very dear friend of mine who I tremendously love, respect, and adore. With this brief introduction, over to you, Uma. I'm looking forward to learning from you.
Yeah, thank you. Thank you, Amita. It's been really great to take part in this program. You've done a wonderful job. And yeah, without much ado, let me start off with the presentation. Yeah, so let's see what is the role of ultrasound in pleural diseases. I think before going on into the topic as such,
Ma'am, can I request you to share screen, please?
Yeah, I had done that.
No, ma'am. Sorry.
Yeah, is it visible now?
Yes, ma'am.
Sure. Okay. So previously, ultrasound was thought to be the enemy of lung imaging, because lung had a lot of air, so ultrasound was not thought to be a good imaging technology to visualize what is happening in the lung. But it has been a great revolution, which was started by Daniel Lichtenstein, a French physician. He was an internist, and he started using lung ultrasound, and now here we are. In fact, going forward, it might be that the ultrasound is going to replace the stethoscope. So that's how it is going to be. So let's see what is the use of ultrasound in pleural diseases as such. I think my next speaker will talk about the lung ultrasound. So all of us are faced with very similar situations like this. As you see in the chest X-ray, you see a complete whiteout of the lung. So you're very confident. It's almost pushing the heart. You're very confident about getting a fluid. But and then we are reduced to this state, literally begging. So somehow something we have to do so that we are getting the fluid for analysis. So what is the reason for such a dry tap? Many times we end up doing the CT scan, and the CT scan tells us that probably it's a loculated effusion, and that is the reason why there was a dry tap. But just we have to keep in mind that we need not go up to the level of CT scan. We can even just do away with just a simple ultrasound. So ultrasound comes to the rescue. So if you see, many times we see that the ultrasound image is like this. You can see this is the diaphragm. Okay, here you can see the spleen. Okay, this is just below the diaphragm. You can see the spleen, and you can see a lot of spider web like things. Okay, what you see completely black here, this is the rib shadow. Okay, the ultrasound waves will be absorbed by the ribs and it does not allow it to pass beyond the ribs. So here you can see the fluid is completely loculated. That is the reason for dry tap. So what is very easy for us is with the help of the ultrasound probe, we can scan all around the thoracic wall, look at the biggest loculus and then put it confidently our needle in and get the tap. Okay, so this is the ease of ultrasound and the use of ultrasound. Let us see what is the normal pleural anatomy. So all of us know, okay, there's a lung here, rib here. So these are actually what you're seeing in this image will not be seen in the ultrasound. You cannot delineate from the lung from the visceral pleura to the parietal pleura. All you will be seeing are black and white images, some white lines. So this is how it will be visualized. We will not be able to make out whether there's extrapleural fat or the innermost intercostal muscles to the outer muscles. Only thing is you can see the ribs. Okay, the ribs will be seen as shadows beyond which if the ultrasound image will not be passed, and between the ribs you can see the pleura and the lung beyond. So the other thing to be noted is whenever we are seeing in the CT scan, you can see the intercostal stripe like this white line. Okay, this we should not mistake for a pleural fluid. Similarly, in the ultrasound, you won't see this stripe, but straight away, if you are having a pleural effusion, it will be completely black. Whatever you are seeing, fluid will be visualized as a black shadow, and air will look as white. So, just for us to remember is, in the X-ray, all air shadows will look black and fluid will look white. Whereas it is the opposite in ultrasound imaging. Wherever you have fluid, it will be seen as a black image, and wherever you have air, it will be seen as a white shadow. It can change. Say if you have an air bronchogram, you will have a white branching structure. That is the air bronchogram in the ultrasound. So how we are seeing in an X-ray, we can also see in the ultrasound. Okay. So the normal pleural anatomy, I'll just take a few minutes here. You can see this is the linear probe. You can see from the footprint, this is the flat footprint here you can see. This is the chest wall. As I said, you can make out the ribs here. So this is one rib, this is the other rib. So here you are placing the ultrasound in the longitudinal aspect where you are placing the ultrasound in the, up to down direction on the chest wall. So you can see the upper rib and the lower rib, and just below you can see this is the pleural line. So the pleural line is the uppermost white, bright, shining line. It shimmers. So this is called as the dynamic sign. It is called as the, pleural sliding also can be made out. Beyond that, beyond the pleural line, you can see lung as a grainy image. So this grainy image tells us that the underlying lung is normal. So what is the bat wing sign? Bat wing sign is nothing but you can see this is the upper rib, the lower rib, and below that you can see the white line. So this is the pleural line. So this looks like as though a bat is flying towards us. So this was called as a bat wing sign. Another important sign is also evident here. You can see the reflection of the pleural line. So all ultrasound image in the thoracic wall is nothing but interpretation of artifacts. You will not see actually the lung anatomy or the blood vessels or things like that, or whatever we are seeing the image. These are nothing but interpretation of the artifacts. So we saw the uppermost white sparkling line was the pleural line. Just below that, you can see another image like this. This is another white line. This is another white line. So these are nothing but equidistant, reflections of the pleural line. So these are called as A lines. So what is the usage of ultrasound in pleural effusion? The advantage is that it can also characterize the underlying lung parenchyma. Suppose if there is a parenchymal, you see consolidation. So it is easily visible. Ultrasound is easily repeatable. It can be done at the bedside. There is no irradiation and it is point of care. So what we do in our daily practice is that we take the ultrasound machine along with us. So we'll auscultate the patient and also use the ultrasound. So it gives us a lot more information about what is happening to the patient. Here you can see. So you can see in this image here. So the upper image shows this is the chest wall. This is the cardiac probe, you can see. So all pleural fluid will look as black. So this is the pleural fluid, this is the liver, and any interface between the two structures, two different echogenic structures. Say for example, fluid is black and you have air is white. So in between, if you have an interface, that's where you will see like a bright white structure. So that is why pleura is looking as a white structure, because it's an interface between the chest wall, which has a different echogenicity as compared to the lung. So similarly, here you have a liver and you have the underlying consolidated or collapsed lung. So you have an interface. That's why the diaphragm will look like a bright white line. So here in the video below, here you can see this is the diaphragm. So any interface will look as a white line. So this is the diaphragm. This is the pleural fluid. And here you can see the lung, which is, shaking like a jellyfish. So this is called as a jellyfish sign in the pleural fluid. So what is the advantage of pleural effusion? So here you can see clinical examination, you need lot more fluid, more than 300 ml only. Then only if it is present, then you can do percussion and then make out, okay, is there fluid or not. Whereas CT scan can detect the fluid, but still there's a lot of risk. Like you have to carry the, push the patient to the CT suite, and patient is exposed to radiation. Compared to that, radiograph also is useful. Again, you need lot of fluid. More than 200 ml of fluid needs to be there just to blunt the CP angle. Compared to all these modalities, ultrasound is much more easy because it can even detect even 5 to 20 ml of fluid. It is 100% sensitive and you can take an immediate clinical action. You can place your probe and as soon as you see the fluid, you're confident enough that, okay, this much of fluid is there and you can put your needle in to do your diagnostic aspirate. And you can also make out not only whether fluid is present or not, what is the type of fluid. Is it transudate or is it exudate? Just by having a look at the fluid, you can make out. And you can also assess the underlying lung. It can be repeated n number of times. So no need for worry that, okay, patient is exposed for more radiation either for the X-ray or the CT scan. And you can also keep the ultrasound image recorded for future comparison. So what are the basic signs for pleural effusion? So here I have highlighted few. So the first is the quartz sign. You have the sinusoid sign and the jellyfish sign. Already in the previous video, we saw what was the jellyfish sign. You have lot of fluid which is looking black, and in the fluid you have the lungs which is dancing like a jellyfish. That is called as the jellyfish sign. What is the quartz sign? Quartz sign is nothing but where when you're placing your ultrasound probe, you see the upper and the lower rib, and this is the lung border. Wherever there's a very small amount of effusion, the lung is just pushed below. So it forms like a quadrilateral line. So this is called as the quartz sign, where minimal pleural effusion can be visualized. So here you can see in your video also, this is the very minimal pleural effusion. You can see the rib shadows also coming and going. There are of course other artifacts also here seen. These are B lines, which my next speaker will be dealing with. So the next sign is the sinusoid sign. Here the ultrasound is placed in the M mode. M mode is nothing but where you drop one particular ultrasound beam. So B mode is what is called as a brightness mode. What the images we saw in the previous slides, they were B mode, where it is brightness mode, where you can see the movement very well. Here the ultrasound is a single beam of ultrasound is passed through, and the movement across the ultrasound beam is visualized as a screen over here. So here you can see this is the top of the screen. So this B mode image is visualized as the M mode here. You can see this is the top of the image. This is the skin, subcutaneous plane. And here you can see you are not able to make out the pleural line. In fact, this is the collapsed lung because the lung is moving towards like this. Okay, so this forms the sinusoid sign. So if you see in the M mode a sinusoid sign, straight away you know that the lung is moving very well and this is a free flowing effusion. So a lot of information we have got just from this image. So here you can see what are we seeing here. This is a massive effusion, big effusion, and you can see this is the collapsed lung which is moving here. And what is beyond that, whenever there is a massive effusion, you can see the vary pattern. What you're seeing here, this is the spine. So the spine sign is usually seen only in a massive effusion. So this is the spine which is seen and massive effusion. Of course, from the appearance of this effusion, we can be sure that this is a transudate because it is completely black. It is clear you are not seeing any floaters here. So this is another image. Again, here you can see this is the diaphragm. As I explained, any interface will look as a bright white line. So diaphragm is an interface. You can see this is the diaphragm. This is the liver. The liver appears definitely different from the normal liver. It is usually shrunken. So here you can see this is the shrunken image of the liver. You can see there is fluid both around the liver and above the liver. So probably this is cirrhosis liver with ascites as well as a massive effusion. And beyond the effusion, again here you can see the spine. Okay, so spine sign usually is seen in a massive effusion. So massive effusion spine sign, a smaller effusion quad sign. So not only that, most of the time whenever we do ultrasound workshop, the first question people ask is how will you assess the amount of effusion? So our standard answer is there's no point in assessing the amount of pleural effusion. So regardless of the effusion, if it is minimal, you are going to tap for a diagnostic tap. If it is massive, depending on whether it's a transudate or exudate, your further management is going to be based on that, not on the amount of effusion. Of course, if it is minimal, small and moderate, of course, it is going to help us in further, fine tuning our management. But a rough idea we can make. So what we do is at the PLAPS index. PLAPS index is nothing but when the patient is lying supine, the posterior most part. Okay, the posterior and the lateral most part, you are putting your ultrasound probe. We can measure the distance between the pleural and the lung line. So if it is just 0.3 centimeters, then we can approximately say that the amount of effusion present is 15 to 30 ml. So here I have measured this distance. So this is the distance that we usually measure. So if it is just 0.3, this is the amount. So usually it goes as doubles. Okay. So if it is 1 centimeter, then the amount of fluid is double. So it is around 70 to 150 ml. If the distance is around 2 centimeters, it is around 300 to 60, so on and so forth. It just, that because what we are measuring is 2D by the ultrasound, but what is there on the patient is 3-dimensional. So approximately we can see. So 6 centimeters is the maximum distance because beyond 6 centimeters, you will see the posterior aspect. So it is not possible to have a more distance than 6 centimeters. So here you can see this distance is just around probably less than a centimeter. So this person has a minimal pleural effusion. So what is the use of ultrasound in thoracentesis? So now all of us know even BTS guidelines promotes or it mandates that all pleural aspiration should be done under ultrasound guidance. So even if you have a very minimal effusion, even if the test is only 1.5 centimeter, it is easy for us if we have an ultrasound image guidance. The success rate increases from 66 to 90% when we have ultrasound guidance, and it reduces the complications of a pleural procedure by 50% if we are using ultrasound. And we need not do, radiology suit, go mark there, come back to the ward and then do, because there again it almost is like a blind tap. What we can do is bedside application of the ultrasound and real-time guidance that reduces the complication rate. So usual complications like dry tap, subdiaphragmatic, many times we have inadvertent installation of the needle, into the liver, or on the left side into the spleen or into the abdomen as such. But this can be because when you do clinical percussion, everything might look dull, but we don't know where to insert the needle. So inadvertent insertion of the needle subdiaphragmatically can be definitely avoided if you are using ultrasound. Post-procedure complications like pneumothorax, laceration, or intercostal artery laceration can also be definitely avoided if you are using ultrasound. So what about locating the intercostal artery? So this is the normal situation, normal area where the intercostal arteries are present. You can see this is the upper rib and this is the pleural line and the lower rib is somewhere here. Usually what textbook says you have the upper rib here, upper rib, lower rib, and just at the lower border of the upper rib you have the intercostal artery. So ultrasound can easily pick up. You can use your ultrasound and use your Doppler and make out the blood vessels. So carefully you can avoid the blood vessels and you can insert your needle here. Compared to this, up to 25% of the time you can have anomalous or sometimes just the variation in the normal anatomic distribution of the intercostal vessel. So sometimes if you have a vessel like this, it is bang in the middle of your needle path. So we might end up having a hemorrhagic tap. So this, if you use ultrasound and just put a Doppler just to see where your intercostal vessels are, we can definitely avoid complications. Another important use is before dilating. Many times we see that, just for a small effusion or, a simple complicated empyema, we use the pigtail. Sometimes what happens, the pigtail is not in position. It is getting curled up in the subcutaneous plane. So to avoid this, always we should make sure that when you're using the Seldinger techniques, make sure that your guide wire is inside the fluid. Definitely, you will never go wrong. You can make sure that your pigtail is inserted properly inside. Another important use is you can differentiate whether the pleural fluid is malignant or not, whether it is a simple benign pleural effusion or it is malignant. Whenever we see, so this is the CT scan. In the CT scan, what is seen? If the pleura is more than 1 centimeter thick, or if you have mediastinal pleura which is thickened, or if you have lumps in the CT scan, it is more a sign of malignancy. Similarly, in the ultrasound also, if you see if it is more than 0.8 to 1 centimeter thick, you can make out. When you are placing your ultrasound probe, you can make out the pleural thickening. Similarly, these lumps and bumps can also be made out in the ultrasound even better than the CT scan. For pleural effusion alone, ultrasound is a better modality than the CT scan. So a pleural thickness of more than 1 centimeter is more suggestive of a malignant pleural effusion. So another thing is if you're seeing lumps like this. So here you can see this is the collapsed lung, which is again, waving around. If you see, deposits on the diaphragm, definitely this is more towards, you can say that it is diagnostic of a pleural malignancy. Of course, you have to take the biopsy to characterize it. Not only that, you can make out the lumps and bumps. It will also help us to guide our needle and take. So you need not do, I go against Amita. Amita is doing a thoracoscopy workshop. But if you're seeing an image like this, even without opening the patient's chest wall or introducing your thoracoscopy, you can do a guided biopsy. So here you can see the pathway of the needle. This is the linear probe. So linear probe is best because it has a very high resolution, but it will not penetrate deep in. So whatever near structures you want very clear picture, you can use your linear probe. So here you can see the path of the needle. You can see how close the lung is. So you can do even daring procedures, but of course you need to have expertise. This is the thickened pleura. This is more than 1 centimeter. So each of these dots are, placed at 1 centimeter distance. So this is more than 1 centimeter. easily we can do the pleural biopsy by the ultrasound guidance. So another important use of ultrasound is prior to thoracoscopy. This helps us to mark the diaphragm, look at the site of the puncture, because many times what happens when there is a massive effusion, the diaphragm is pushed down. What we do is, if you use your thoracoscope to insert, the pleural fluid is drained, what happens? Diaphragm rises up. So a lot of the time, patients end up with having a lot of diaphragmatic irritation, pain. So at least by ultrasound, you mark the diaphragm, make sure that you're well away from the diaphragm, at least 2 or 3 centimeters or 2 or 3 rib spaces above the diaphragm. By the help of the ultrasound, you can mark there and then insert your thoracoscope. And make sure that you're looking at the lung sliding. Sometimes, even if you're having an effusion, lung can be adherent here and there. So inadvertently, if you insert the thoracoscope at that point, you end up injuring the lung. So this can be avoided definitely by using your thoracoscope. So here you can see, this is a massive effusion where you can see the diaphragm has completely become concave. Okay. So here, this is the effusion. So easily you can mark your area, at least say this is the diaphragm, at least 3 to 4 centimeters away from the diaphragm we can mark. So what do we do? Normally we scan the fluid. Okay. I'm not sure if this video is going to play. So this video actually was troubling me. Usually it was not playing. Okay, I hope this is visible now. So this is what we do. Normally, once the patient is on your thoracoscopy table. Okay. So,
Uma, the slides need to be shared. They're not shared as yet.
Okay, sorry.
Okay.
Is it visible now?
Not yet.
Ma'am, from Zoom, you again press share screen.
I think it's okay. I'll skip the. Okay. So when we have complicated effusions like this, so you see the X-ray, it is definitely loculated straight away. You know probably this is a complicated effusion. You need not do a CT scan. If you just do an ultrasound and you see lot of specks like this, so this is what is called as a plankton sign. Okay, it looks like many of us would have seen the National Geographic, where in the sea bed you can see a lot of planktons floating. So this effusion, it looks exactly like that. So all these specks, what we see, these are nothing but the debris in the pleural fluid which are floating around. Whenever you see a plankton sign, you know that this is definitely an empyema. There is no doubt about this. So I was mentioning before, we can sometimes have the lung adherent like this. So prior to thoracoscopy, we need to make sure, so you can see the corresponding ultrasound image. If you see that the lung is, touching the chest wall and adherent to this, we can be very sure and avoid that space to introduce a thoracoscope. So this is a classical empyema. Here you can see the thoracoscopic image. You can see how, lot of thick adhesions are there. In the ultrasound image, we can make out this is almost like a spider web. So if you see a spider web, you know straight away that this effusion is not a transudate. It's an exudate. So by ultrasound itself, we are able to make out whether it's a transudate or exudate. If you see a spider web or a plankton sign, you know that it's an exudate. So that tells us a gist about what are the signs of a pleural effusion in the ultrasound. We saw the quad sign, we saw the jellyfish sign, we saw the plankton sign, the spider web sign, and we saw the sinusoid sign. Now, what about basic signs for pneumothorax? Okay, so most important is lung sliding. And lung sliding, of course, if it is present, you know that the underlying lung is normal. But lung sliding is present, still you are doubtful. It is not 100% confirmatory that there is a pneumothorax. Whereas if you are able to make out a lung point, then it is 100% confirmatory. Sometimes even by CT you might not pick up a pneumothorax, but by ultrasound, if you are able to pick up a lung point, it is 100% confirmatory that there is an underlying pneumothorax. Now, what are these signs? Lung sliding is nothing but the movement of, the pleural line which slides. Okay. Here, what we are seeing is the whole image, that is your upper part of the image. This skin, the subcutaneous tissue, and all the muscles, plus the pleural line, all are moving together. It is moving like this. It's not sliding one over the other like this. It's all moving en masse like this. So this is absent lung sliding. Another important point, that is the lung point, is depicted here. You can see one half of the image. Okay, there is no lung sliding here, but the other half of the image, you can see one half is static, the other half is sliding. So this pleural line is moving. And here, beyond this, you can see some sticky images also. So this is the lung point. Lung point is nothing but, say for example, here you can see in this image, if you place the ultrasound probe at exact place where the lung is collapsed. Okay. So beyond this, here you can see this is the part of the pneumothorax and where the lung is collapsed. So if you are able to trace out as you are scanning the patient's chest wall, this point where the lung is meeting the chest wall as well as the pneumothorax is meeting the chest wall, this particular point you will have half lung sliding and half not sliding. So this is the lung point. So if you have lung point, there is no lung sliding. Another important point is there should not be any P lines or no lung pulse. When all these parameters are confirmed, then it is 100% sure that there is an underlying pneumothorax. Another way to confirm the pneumothorax is when you put the ultrasound in the M mode. So what happens in the M mode? In the previous images we saw in the M mode, you saw the pleural line, and beyond that, it's a grainy picture, isn't it? It looks like a seashore. So this is the seashore what we see. So this is the normal lung. This is how it will appear. Whereas when you have a pneumothorax, what is happening in M mode, there is a single ultrasound beam and you have the movement of the lung. So whenever the lung is moving, it will appear like a grainy picture. So this is the seashore sign. But in the pneumothorax, what is happening? There is no movement. Lung is collapsed completely. All you have is air. So this air is picked up as nothing but like a static. So this is called as the stratosphere sign or the barcode sign. And exactly at the lung point, you will see an image like this, where you have one half you have the stratosphere sign and the other half you have the seashore sign. So if that is seen in the M mode, then it is the lung point in the M mode. So this is also confirmatory of a pneumothorax. Another important application of ultrasound is you have to, once you have finished your thoracoscopy or not only thoracoscopy, you have finished your ultrasound procedure, either a diagnostic tap or you have done a pleural biopsy, you have to make sure that the procedure has gone off smoothly. Post-procedure complications we can look. So here you can see by immediately after the procedure, you do your scan. Here again, this is another lung point. Here you can see half is moving and half is not moving. So if you see this image, even before shifting the patient to the X-ray, you know that, okay, we have created a pneumothorax. Or, for example, after procedure, next day you see an image like this. So here you can see the diaphragm, we can see the plankton sign. So probably patient has developed a post-procedure infection. So we saw many advantages and application of the ultrasound in the pleural procedure. What are the other advantages? So you have other findings, not only the effusion, other findings to confirm the diagnosis. Just on the top of the diaphragm, if you see lumps, okay, it's a malignant effusion. Or if you are able to see, you're doing the ultrasound, not only the effusion, but you are seeing something like this. This is called as a shred sign, where you can see this is the lung which is touching the chest wall, and you can see a irregular margin here. So it is like a shredded paper, and you can see lot of white specks here. This is a consolidation. So this is called as a C-profile consolidation. So if you see this, you know that the effusion is secondary to a consolidation. So this is a parapneumonic effusion. So not only the effusion, what is the etiology of the effusion also can be made out by the use of the ultrasound. So I think this was more for a live audience, but definitely I can still ask, what is the probable cause of the effusion here? Okay, probably once I finish my talk, we can revisit this slide. So I think by now everybody will know this. This is the plankton sign. Another important advantage is, even if you have a very minimal effusion, so here you can see this is the diaphragm, here we can see the lung, and we can see the needle coming and going, which is very close to the lung. So you can be very confident of doing your safe tap and not creating the pneumothorax. So this is the advantage. So you will be able to guide your procedure in a very, very careful manner and avoid the complications. So thanks a lot. So what I spoke about is the use of ultrasound only in pleural diseases. We saw the various signs, what are the effusion, what are the types of effusion, and utility of the ultrasound in the pleural procedures. I'm happy to take any questions.
Thank you, ma'am. I think we'll take the questions in the end, in the panel discussion. And thank you, ma'am. It was an excellent lecture. It's always a pleasure to hear you and learn every time new science. And I especially like this part where you were showing the comparative images of thoracoscopy and ultrasound. It makes so much sense for somebody just learning, how exactly it looks. So thank you, ma'am. Thank you for the lecture. It was an excellent lecture. Now I would request you to hang around for the panel discussion.
Sure.
And I would like to now introduce my next speaker. He's Dr. Nishant Sinha. He's a senior respiratory consultant at Continental Hospital, Hyderabad. He has had some overseas training in UK for 2 years and had a thoracic ultrasound course there. And he's been awarded by the Indian Chest Society Travel Grant in NAPCON 2009. He was part of our BronchoCon which was held in Mumbai last year. And I would like to welcome him to give his next talk. And before I hand over the stage to him, I would request all the audience just one more invitation. We have our BronchoCon Kochi happening in May 24, 25, 26. I'm sure it will be an excellent program, and I'm sure they are trying to beat us with the program that we had. So looking forward to that, and I hope to see all of you there. Dr. Nishant, please take over.
Thank you, Dr. Mehul, for the wonderful introduction. First of all, a warm good evening to you all. I think it's a packed program, and I must thank the IAP for giving me this opportunity to talk here, and especially Dr. Amita Nene, who has given me this task. But my topic was actually lung parenchymal ultrasound, so I'll come straight to it. I'll share my slide now. So I think it's seen now. Is it clear? Am I audible?
Yes, sir.
Yeah, so basically this is the topic, and I'm going to avoid pleura completely. I'm not going to speak anything on pleura because I thought if it was for me, then I would have, it would have been more easy for me. Parenchyma is more difficult. And if you see this picture and this, what I put in the left side, there are two probes. One is lesion touching the chest wall and the pleura, which is very easy for us to diagnose. Other is in the lung, and the ultrasound is trying to see that. So that is the road ahead. We have to do something to see those things in the ultrasound. So I'll straight come to my talk now. So this is overview of my talk. I've tried to make it very simple with some videos. My patients have consented to show those videos. So I'll talk few basic points about lung ultrasound, namely anatomy and physics. And then I'll come to bedside lung ultrasound for lung parenchyma only, not for the pleura. In our day-to-day practice, which change the management of our patients. And then I'll come to glue protocol, few slides. And if there's a time, I'll speak something more. So you need to know a bit of physics and anatomy when you're trying to do ultrasound. That's called nomology. You need to know gain, depth, probe. You need to know your screen anatomy. You need to know your probe anatomy. So this is the picture you can see here. Patient is lying and the probe is kept like that. There's a arrow marked in the probe and there's an arrow on the screen. So what is towards the arrow is the cranial and below that is the caudal. Same thing applies on the screen. If you divide the screen in two parts, what is here to the left is the cranial, to the right is caudal. So this orientation has to be in your mind, and that's exactly what is shown in the right side of the picture. You're seeing the diaphragm, you're seeing the liver or spleen, then you're seeing the effusion. So the lung comes first, then effusion, then diaphragm, then liver and spleen. So please keep this in your mind, and then we move forward. So basically, there are different frequency of probes. We know very clear that if the frequency is high, it can only see the superficial structures because it has got lower wavelength, but it has got better resolution. If the frequency is low, it can go deeper because it has got a longer wavelength, but at the cost of poor resolution. So you have to keep this in mind when you do your ultrasound day-to-day practice. So you need to adjust your gain. Suppose some other person was doing ultrasound and he put gain at a very low, and you just started in a hurry doing ultrasound, you'll see everything black. And somebody else changes, the nurse just touched the probe and she made it high gain, it will look everything white. So you need to adjust to this grayscale. What is this grayscale? Grayscale is what looks like this. You're seeing liver that looks like a soft tissue ultrasound picture. Then you're seeing anechoic fluid here, and this is spine here. So A is the fluid, B is the liver, and C is the spine. So this is also very important when you are doing in your actual patients. So this already I have shown. Pleura, that's what is important. All the lesions, almost everything abuts to the pleura, and we try to differentiate everything because of that artifact from the ultrasound wave, which gets reflected from the pleura. So coming to pleural line, it's the interface between the soft tissue of chest wall and the lung. Basically, that's the pleural line where the visceral and parietal pleura meets, and that's called pleural line. A line is just the reverberation artifacts of pleural line, which just goes below that. B line is vertical lines which erase the A lines, and they're also called comet tail images. I'll just come to that exactly how they look. So this is how it is. This is your rib here. This is one rib. This is another rib, and between this is a pleural line, and these are A lines. So A lines are equidistant vertically. B lines are equidistant horizontally on the screen. So this is how it is. D is equal to D1 equal to D2. So you have to remember this. Whenever these B lines are very much florid, you need to think of pulmonary edema. If they are less than 3, it's normal. So what is the origin of A and B lines? So basically A lines are nothing but they are the artifacts which are reflected from the pleura down to the screen, and they're always horizontal. And B lines are nothing but whenever you have interlobular septal thickening, the beam is having ultrasound, it comes, it reflects again, goes to the pleura, again reflects, goes to pleura, again reflects. So that is called reflection artifacts. So 1, 2, 3, 4 like that. So when they all summate, they form the B line. So this is exactly what it is. First reflection, second reflection, third reflection, fourth. So it's called nth reflection, and that's called comet tail artifact. So this happens only when there's interlobular septal thickening or there is a abnormality at that level. And this one more thing is very important, that if you're in pneumothorax, you'll never see B line because the pleura here is separated. The parietal visceral pleura are gone. They're like this. So this cannot reflect. So this is absent in pneumothorax. Keep this in your mind because this is the gist of next talk. So in our day-to-day practice, what I want to speak here is I'll have case scenarios because it's very difficult to just go on talking theory here. So how to differentiate pulmonary edema from other cause of breathlessness in the bedside, how to identify consolidation accurately, how to differentiate atelectasis from consolidation if needed, how to monitor your ILD or a patient with interstitial lung disease, what is the role of ultrasound, and of course our ICU referrals, patients with ARDS, whether there's improvement or deterioration, you can't ship the patient for HRCT, compliance is not getting better, and so suddenly you get a call for a patient with knee onset breathlessness and hemithorax whiteout. There can be atelectasis, there can be consolidation, there can be effusion, and your ICU physician asking for a bronchoscopy. So you need to defend it and ask, is it really required? There, ultrasound helps. If you do ultrasound and the whiteout is because of effusion, you won't do bronchoscopy. You'll just tap the fluid. So this is now coming to pulmonary edema. So remember one thing very clearly: air means A lines, and whenever the water is replacing the air, it means B lines. It's very simple. So as the pathophysiology of disease evolves, suppose you take pulmonary edema, the air is replaced by water, or for that matter, if there is any other reason of interstitial pattern, that pattern is changed. So A profile shifts to B profile, and this is how pulmonary edema evolves. So as the water content of lung increases, the number of B lines keep increasing till this level where it is highest. And this is frank pulmonary edema here with classical B profile. Why this is important? Because when you see this profile, you need to think about dialysis, get a cardiology referral, do a good echocardiogram, look at the cardiac causes of condition of breathlessness for the patient. This is a very clear-cut example of interstitial syndrome. Here you are seeing one rib, which is black here. This is another rib, superior rib, inferior rib. This is a pleural line. And you are seeing B profile, B lines, 1, 2, 3, 4, many B lines. So when the B lines are more than 3 or 5 or 6 or whatever, it is pulmonary edema. So this is interstitial pattern of cardiogenic pulmonary edema. So you can score the B line actually. There are different patterns, but one of this is what I could get. So you can take second, third, fourth, fifth intercostal space, use mid-axial line, anterior line, mid-clavicular line, and calculate the number of B lines in that. If the total number of B lines is more than 30, the score is 3, and it is florid pulmonary edema. And depending on that, you can decide how much this patient could have extravascular lung water. There is a correlation. Studies are there, but based on this, you can take a call for your patient. So a typical example of patient, suppose the patient is a COPD patient with a coronary artery disease, EF is 50%, comes to you with breathlessness, there's a wheeze also, you have done venous Dopplers, no DVT. Clinically, you think COPD exertion, but the moment you put the ultrasound probe on the chest, anterior or posterior, you are seeing florid B profile. So this patient also has got pulmonary edema. So you need to dialyze the patient, at the same time treat for the COPD exacerbation. But if there's a predominant A profile, we just need to treat COPD exacerbation and you don't need to dialyze. So just I'm giving an example of a case scenario which happens in our day-to-day practice of using ultrasound in a breathless patient. Now, this is another example of a patient was tapped, pleural fluid is removed and suddenly became breathless. So very interesting, X-ray couldn't pick up much. You can see the X-ray, it looks essentially okay. But if you put the ultrasound probe anteriorly, these are again ribs left and right. In between, you are seeing florid B profile with almost causing white lung pattern. So this is classical of re-expansion pulmonary edema which happened after the pleural tap. Otherwise, you might be thinking, have I made a pneumothorax? Have I created hemothorax and whatnot? But actually, X-ray is not showing pneumothorax here. But still, before X-ray is done, you would be apprehensive. So put the ultrasound probe and make sure that lung is sliding. And as I told you, if you are seeing B lines, pneumothorax is almost absent. It is not there because the pleura is like this. I mean, pleura is opposed at that time. So next is consolidation. So the basic concept is almost 99% of the consolidation abuts the pleura. This is the dictum, you should remember this. And there's an older study which compared CT as a gold standard, and they found sensitivity and specificity to ultrasound to detect consolidation was close to 98%. So it's a very strong point. So now coming to the actual cases, now I just want to show a picture of ultrasound bronchogram. This is a 60-year-old male medical ward admission referred to me for breathlessness, cough and fever for 3 days. The referring unit is planning for HRCT. I go to the bedside and see the patient. I'm quite sure it's the consolidation. I tell them not to do HRCT. Patient has consented to show this. So this is here. You can see here. This is one rib, superior rib, inferior rib. You are seeing the diaphragm here. This is the liver here. Below that is the kidney. And here you are seeing the dynamic air bronchogram. If you are seeing this in this patient, which is actually moving this patient, you can see dynamic air bronchogram. There is no effusion here. You are almost 100% sure that this is consolidation and you don't want to do HRCT here. You start antibiotic and patient gets better and gets discharged. So this was right lower lobe cap. History is just 3 to 4 days. So I don't think HRCT will add anything here. So it was cancelled. So next case, this was a very interesting case. This patient is referred to me again from nephrology unit. Patient has got stage 4 CKD, came with left loin pain. They were working him off a pyelonephritis, which was not there. So ultrasound was negative. I'm sorry, renal ultrasound was normal. He's ex-smoker, and they called me very, very casual referral for a right pillow fibrosis because of old pulmonary tuberculosis for this. So I just saw the X-ray and I was not happy with the left lower zone, which looked little suspicious. So I go to bedside, see the patient, and just put the probe there, and you can see this. This extreme left base. This is your diaphragm here. This is your spleen. And you can see here translobar consolidation with dynamic air bronchogram. Very minimal effusion there. Some of you might be thinking, is it collapse? So I'll come to that. So a little higher. So this air bronchogram is quite dynamic. It's not static. So I was pretty sure it's consolidation, and a little higher intercostal space we see. You can see these are B lines, and you can see dynamic air bronchogram here. Small effusion. So this patient didn't have much cough and classical symptoms of this much pneumonia. So I had to ask for CT scan here just to make sure that I'm not missing any post-obstructive lesion here. I did bronchoscopy also. There was no bronchial lesion. There was but BAL showed MDR pseudomonas, and TB was of course ruled out. His CRP was 312. Procal was very high TLC here. So this guy was almost very septic with left lower lobe massive consolidation, which was picked up in the CT scan. This is translobar consolidation, and patient was sitting there for I think 2 days when I was called for referral. So these are the cases which should be picked up earlier with ultrasound, and it helps to accurately plan and manage the patient. And patient got better with antibiotics after and got discharged. So the next question is, how do you differentiate between collapse from consolidation? So consolidation will have dynamic air bronchogram, which I showed 2 cases. Collapse will have static air bronchogram, and also morphology will be like collapse. So I'll show you the case here. This is a case again, hemithorax whiteout, central mediastinum. But if you put the ultrasound probe, this is a left pleural lobe mass. This is a stage 4 terminal lung cancer. But this was a referral I got because of this. So I just put the probe anteriorly. You see here. This is a classical collapse. This is a effusion here, triangular collapse. There are some air bronchogram, but they're not at all dynamic. They're all static. So this is how collapse will look. And when you see this, you say it is collapse. And you plan accordingly. If you want to tap the fluid a bit and then relieve the patient from breathlessness. So this is another example of atelectasis. This is jellyfish sign here. You can see here again static air bronchogram here. You see this? This is a effusion here, diaphragm here. And you can see the low lobe atelectasis diaphragm, and this is the liver or spleen, whatever, and spine is here. So here again, you can't see any dynamic air bronchograms. This again is atelectasis. So this is how to differentiate the consolidation from collapse. Coming to ARDS, now a third thing, ARDS ultrasound per se, you cannot diagnose it and give full credit that you have made a diagnosis. But yes, ultrasound is a good tool for follow-up your patient. And I'll show you the case. So this is a hypothetical, slide showing how ARDS evolves from normal to early, which is called stress, and to advanced, which is called distress. So if it is normal, I said you normal means air means A lines. The moment it is interstitial thickening starts happening, A lines are replaced by B lines. So if it is still early, you can revert it, it will get better. But when it goes to advanced, the B lines are quite thick and they are fixed. So that is called distress, and that is called fixed ultrasound lung comets, and that is where ARDS comes. But this is a very interesting study, actually, one of the best papers I read recently, where they looked at ARDS after viral pneumonia. They took COVID-19 as a prototype, and this was done in UK, 3-4 centers, and it's a very good study, actually. They looked at this. This slide is very important. So if you have got aerated lung, which is A profile, A lines will be there. If there's partial aeration, you start having B profile. If there's a complete deaeration, you have consolidation or classical ARDS. So, but if patient has to improve, he will follow this path. From critical, he becomes little severe and he becomes moderate. If patient has to deteriorate, he follows this path. So this is what you have to remember, and you will have lung sliding initially, but in advanced ARDS, mind you, you may not see classical good lung sliding. Lung will be very sluggish. And if you put M mode, you may have even stratospheric sign. And so this is how the evolution of ARDS happens. And in this study, they looked at these things. So if the patient had mild to very pre to moderate disease, they had very less B lines. But if it started with to increase in severity, the B lines started to increase. They became more fragmented. The pleural line became more thick, and it was very critical. Then it was all over the place. There was anterior consolidation, which is called C profile, and this all matched with the patient's clinical profile. Patient, if you look at the critical ultrasound picture, that matched with patient requiring mechanical ventilation. Some of them went to ECMO. So I'll show a real case. Actually, I took this example because I had to show ARDS here. So 60-year-old male admitted with type 1 respiratory failure in our MIC. I got a referral to see this patient. He has got H1N1 bronchopneumonia, severe ARDS. He is on venous ECMO. Yesterday it was day 15 when I scanned his chest again. He's being weaned now, he's improving. But what is important here is this. This is a CT scan and X-ray 2 weeks back. You can see the ECMO cannula here is 82. Now, this is just before the ECMO was put. You can see such bad whiteout lung. Now, after you have started ECMO patient in high supports, you can't shift him daily for a CT scan to process, to assess the progress. So here comes the role of ultrasound, which is very important. So yesterday, actually, I went and just did his profiling. I had done earlier that time also, and you can see this. If I put the carilinear probe anteriorly in the anterior chest wall, this is what it looked. You are seeing the ribs, pleura is quite thickened, and you are seeing this profile. But this is, I'm telling you, this is better than what it was 2 weeks back. And when you are seeing anterior consolidation, this is called C profile. This is classical for ARDS. Then same thing when you are seeing in M mode, there's a ribs here. You are seeing fragmented pleura. You are seeing B lines, which are actually not very uniform. They are a bit fragmented. You can see that they go up to half of screen and then they are disappearing. So that is important because in pulmonary edema, you will have smooth this and they go up to periphery. And then we have something called Plapp's point. So this is the Plapp's point where you are seeing the diaphragm and there's a small collapse consolidation, a very small effusion. And I'll show you where is the Plapp's point. Will come. So this is the Plapp's point. I've concentrated for showing this. So Plapp's point is here, just the posterior axial line in the lower blue point. I'll show that in the next slide. So when you see this, this is actually much better than what it was 2 weeks back. So we have been tracking this and we can say that patient has been getting better. And this corresponds to the X-ray also. This is X-ray at present. Yesterday X-ray, when I was doing the ultrasound, this is X-ray 2 weeks back. So this is giving us confidence that the patient is improving, even other parameters have improved. So ultrasound really helped us in this case. And if I take this as this case as the study which I showed, so this was in the right side, you're seeing the X-ray of the patient 2 weeks back. He slowly improved and now he's coming towards this side, but he's somewhere here in between these two profiles. This X-ray is there. He's still, I don't think he can come in this one. It's very difficult. It will take time, but he's somewhere in between this and this. So he's doing good. So, but you need to remember that in some cases of severe ARDS, they may be a little atypical. Pleural sliding may be sluggish or slow. You may not be seeing it on M mode. You may have a stratosphere sign also. Then you get confused with pneumothorax. But in those cases, look for lung pulse. As Dr. Puma was saying about lung pulse, I'll tell you here what is lung pulse. So in those cases, when you are seeing a stratosphere sign and you are sure it is not pneumothorax, then look for lung pulse. So lung pulse will be present in ARDS, but it's going to be absent in pneumothorax. Very important, because what is lung pulse actually? The lung pulse is this. It is created by a cardiac impulse being transmitted to the lungs to be picked up by the ultrasound probe. So if you put M mode, this vertical line which you are seeing is lung pulse. These are all vertical lines, which is called lung pulse. And they're called T lines. So when you are seeing this in a patient with severe ARDS, it could be just ARDS and this stratosphere sign is not pneumothorax. Okay, so that is important. So these are differentials of M mode and lung pulse. So in a normal lung, you will have seashore sign, lung pulse is present. In pneumothorax, stratosphere, lung pulse absent. But in severe ARDS, you can still have stratosphere, but you'll have lung pulse present. Very important. And also you can have stratosphere in patients with one lung intubation. In all those cases, lung pulse are present. So whenever you are seeing stratosphere, don't just jump and say that this is pneumothorax. Okay, let's start. So you need to look for lung point and also for lung pulse. Important. So now to differentiate ARDS from pulmonary edema, it's easy. It's not difficult. I will say it's easy because of this table. In acute cardiac pulmonary edema, the B lines are present. They are very uniform and the pleural line is thin. But if you take ARDS, the B lines are very erratic. They may go to the half of screen and they may not reach the periphery. Pleural line is very irregular or thickened. And lung pulse is always absent in pulmonary edema, but it can be present in ARDS. So there are few, but you'll have some clinical clue in such patients. So I don't think ultrasound will be just full criteria to differentiate, but you'll have idea what we are dealing with. Now coming to role of ultrasound in ILD, very interesting study by Dr. Richa Gupta from CMC Vellore. And this was presented in ERS. I read it very carefully. So this is very good. They looked at almost 117 patients and they actually looked at people with systemic sclerosis, and they looked at the ultrasound count with the HRCT score. They looked at the B profile, the pleural line thickening, and what they found very interesting data is that with HRCT as a gold standard, which we are using, and if you also use ultrasound parallelly, the sensitivity, specificity, positive predictive value and negative predictive value of lung ultrasound was 100, 98, 90, 99, 100. So it's quite good actually. It's very, very good actually. So this is the future of lung ultrasound, where if you are very confident, you can just do it and get away with HRCT. But I don't think that age has come now. HRCT should be done. But I think in follow-up, this is going to be very important, and it's all about B lines and pleura. You have to be very you have to be practicing it to interpret this regularly. So I showed many cases about lung parenchyma. The last case I showed of lung mass. This is again a referral to me. 16-year-old boy admitted elsewhere for right side effusion, high fever he had for almost 2 weeks. He was given IV antibiotics. They tapped some fluid, which was accelerated. ADA was borderline high. They thought it is TB. They referred to me. I was very sure I'm going to do thoracoscopy here, but things changed, and this is how it is. After seeing the X-ray, should be your next plan? Should we do straight CT scan, or will you do ultrasound? Patient was a bit orthopneic, breathless, so I just did ultrasound first, and I could quantify some fluid there. It was anechoic fluid. But when I kept the probe anteriorly, it was a spot diagnosis, and this is what it is. When I kept the probe, patient has consented for me to show this video. I've taken consent from his family. So when I kept the probe anteriorly, this is what it is. This is the heterogeneous mass-like lesion seen in the anterior chest wall. This is your diaphragm, and there's a probe here. So this is after I put the Seldinger chest tube. After that, I've done again. So immediately I called my IR guy. We discussed about it, and same time we did the biopsy. This was high-grade follicular lymphoma. Thoracoscopy was not necessary here actually. Subsequently, we get a referral here, and this is how it is. This is X-ray after the drain. You can see the lung well expanded, but this is what it is. Quite good improvement. What is important here is putting the probe on the patient is important, because it really helps us to plan. And also, when you have effusion, please put the probe anteriorly also, because this was one case where if I had not put the probe anteriorly, I might have taken it for thoracoscopy. I might have got it known later. With ultrasound, I could know it earlier. So that's the importance of thoracoscopy and putting the probes anteriorly. So coming to blue protocol now. So blue protocol is basically nothing but it's a bedside lung ultrasound in emergency. In a blue patient is breathless. So this is done to cut short our time and also cut short our differential diagnosis of patients who are in our A&E. So this was by Dr. Lichtenstein, 2008. It's quite old. But now after that, he modified 2014 also, the points he has given now. So you need to just learn this, memorize this if you want to know what blue protocol. So A profile, what is A profile? A profile is predominant A lines. What is B profile? Predominant B lines. What is A dash profile? A dash profile is abolished anterior lung sliding with A profile. B dash profile is again abolished lung sliding with B profile. AB profile is both A and B profile, and C profile is if you are seeing anterior consolidation. CLAPS is posterolateral alveolar-pleural syndrome. So if you just keep this in your mind, then you can fare out better to understand blue protocol. So these are the 5 differential diagnoses which he gave, and he came up with these sensitivity and specificity for diagnosing the conditions. So in acutely breathless patient, if you are having predominantly B profile, there's a lung sliding also, then you have high chance of having pulmonary edema. If you have just everything normal, there's A profile, no DVT, no PLAPS, then you could have COPD or asthma exposure. If you have background COPD or asthma, pulmonary embolism cannot be diagnosed with ultrasound just by itself, but it has to be backed up with DVT by venous Doppler. And in that pulmonary embolism, you'll have A profile again. It's not B profile. Pneumothorax already has been talked. You'll have lung point, and also you'll have absence of lung pulse, which already I have told. Pneumonia has got so many things I've showed already in ARDS, pneumonia. So you can have B dash profile, A profile, B profile. C profile is nothing but anterior consolidation, which I've showed in the ARDS. And AV PLAPS is again the PLAPS point which I showed you in the ARDS case. That is also consolidation. So these are all pneumonia profile. But what is more important here, if you see and read it carefully, there is no mention about large pleural effusion, which is not there in this. So that is a separate entity which you have to diagnose and make sure that patient is breathless because of effusion. It will not come in blue protocol. So these are the blue points. So you put your hand on the patient's chest, and this is the upper blue point. This is the lower blue point. Phrenic line is the line where the diaphragm comes, and you have got in the left side upper blue point. Collapse point is nothing but you draw a horizontal line from the lower blue point where it meets the posterior axial line. Somewhere here. This is the point where most of the consolidation, early pleural effusion, everything comes. So you should always check that in an acutely unwell patient to say if he has pneumonia or evolving future problems. So this is a slide, just summary of blue protocol. It shows that if you have got a lung sliding present, the first thing is to look at lung sliding, whether it is present or absent. So if lung sliding is present, you look at if there's a B profile, it's pulmonary edema. See, in talking, it looks very simple, but actually a real patient may be confused. So you need to do it again and again to pick it up. If you have A profile and if you have DVT, then most likely it's pulmonary embolism. If you have A profile and no DVT, then again you should look at PLAPS. Then you could have pneumonia. If there's no PLAPS, then if patient has background COPD or asthma, then it's most likely COPD or asthma exacerbation. If the lung sliding is absent, it's very clear. If there is a line and there is a lung point, there's an absence of lung pulse, it's clear-cut pneumothorax, there's no doubt. But if there is a lung sliding absent, A profile, lung point is not seen, then is the zone which I have talked earlier. You need to look at all those other causes where stratosphere sign is being seen, but lung point is not found. So you need to look at it carefully and then say it is pneumothorax or not. It could be just a whole lung collapse. It could be post-pleural disease. It could be severe ARDS. So there you have to think a bit. And if patient has got B- profile, it means patient has got B- profile is nothing but anterior B profile with absence lung sliding. So that's pneumonia. Again, we have showed in the ARDS slides. So one thing which is very important is pulmonary infarct, which is exception to this, which I told earlier. So suppose patient has got pulmonary embolism with a peripheral pulmonary infarct. What I told earlier is in pulmonary embolism you have A profile, but in this case you'll have localized B profile. Suppose you have a patient in the ER with a localized B profile, chest pain in one lung and the other lung is fine. You need to think of pulmonary embolism. Ask for CTPA immediately. Don't wait. You can do echo also in the interim, but I think that should be your plan next after seeing this picture, because this is how it looks. So in pulmonary embolism without pulmonary infarct, you will have A profile with whatever venous Doppler showing clot or CTPA showing pulmonary embolism. But if there's a peripheral infarct, you will have focal or unilateral B profile, is very important. So just want to stress on that. So I'll be concluding here. This is how I'll conclude. Do not miss clinical examination. Look at the pulse volume, very important. Look at the blood pressure. Look at the respiratory rate. Look at JVP. Examine the lung. All this you have to put together. Before using the probe on the patient, you have some pre-test probability of diagnosis in mind. You can't just put the probe and you want to look something. So you need to have something background pre-test probability of diagnosis, and it's a robust tool to decide plan of management. So I'll conclude my talk. Thank you.
Thank you, Dr. Nishant. You said it's a tough job, but you made it look so easy. There are so many things that you can do with an ultrasound, which I'm sure everybody might have realized. It's not just the X-ray and the CT scans. This is a tool in your hand which can help you diagnose almost everything if you have the good clinical picture, good clinical acumen, and you know all the details that you showed. And thank you for an excellent talk. All the images that you showed were so good. So now we come to the next part of our webinar, which is going to be the panel discussion. And I'm so happy that already questions are pouring in, and I'm sure Dr. Rajadhar has his work cut out. I'm sure in the hands-on workshop, you'll get a lot of questions answered there when you're doing the ultrasound in front of the demonstrators. But currently, let me introduce the captain of the ship today, Dr. Rajadhar. Dr. Rajadhar needs no introduction. He is a senior pulmonologist from Fortis Escorts, and he is the head of department there. Sorry, I'm sorry. He is the director and head of department of pulmonology at C.K. Birla Hospitals, Kolkata. He is the secretary of Indian Chest Society, and is the joint secretary for Indian Association for Oncology. Sir, can you take over, please?
Thank you very much, Mehul. And congratulations, you guys do a great job. Also to Amita for putting the IAB meetings, the thoracoscopy workshop together. I think the attendance says it all. The volume of people who've actually attended this workshop, this meeting, speaks volumes of the quality that has been delivered during these. Now, I'll have to give a disclaimer to start with. So I was not supposed to be moderating this session because I'm no expert at ultrasound chest. So I know the basics, and one of the people I have learned from is also on this platform, Dr. Uma Devraj, Dr. Priya Ramchandran, for whom I've stepped in today, are people who've come and trained candidates, including myself, in ultrasound of the chest on multiple occasions. And I've had the fortune of attending these workshops, which they have done. So I think it's good that I give you a perspective that a lot of audiences will share. I'll ask some questions, a lot of which have already been put forward by the two speakers who've done a brilliant job. So I've heard Dr. Uma Devraj speak on multiple occasions before, and I'm always enthralled by the way she makes difficult things simple. But Nishant, I heard you for the first time, and I have to say, the way you discussed a difficult topic and made it easy, for at least for me, and I'm sure a lot of the audience who are logged in today, was absolutely amazing. So kudos. So both Uma and Nishant will be a part of this panel discussion now. The other people whom I want to bring in, and you can see the introduction on the slide in front of you. So Dr. Akhilesh Kunur, who has done his post-graduation from SCB Medical College in Cuttack. Very important for us, is the organizing secretary for BronchoCon 2024. And you've just heard Mehul say that we are sure that BronchoCon 2024 is going to rock it. So we look forward, Akhilesh, to you performing miracles with BronchoCon 2024. He's got multiple other accolades in front of you. Very important, he's a professor at Amrita Institute of Medical Sciences in Kochi, Kerala. And I was very impressed to see that he's the NTP-EP State Task Force Vice Chairman and the coordinator of the Amrita Pulmonary Rehab Program. So you see, he's a holistic pulmonologist with excellence in various facets of pulmonology. He's got multiple awards, the Young Pulmonology Appreciation Award, the Young Pulmonologist Award, the Best Oral Presentation Award at NAPCON and at APCCM. The next person I have the privilege of introducing, a short CV, but a very erudite, again, professor in pulmonary medicine, Dr. Kiran Vishnu Narayanan from the Government Medical College, Thiruvananthapuram. Again, a lot of experience in academics, a lot of experience in organization, Joint Organizing Secretary, Pulmocon 2023, Joint Organizing Secretary, NAPCON 2019, Joint Organizing Secretary, APCCN 2021-22, and again, will play a very active part in organization of BronchoCon 2024. Last but not the least, I've got Dr. Abhishek Prajapati, comes from a different part of the country. So Dr. Abhishek Prajapati has done a PhD in medicine, which I was very impressed to see. He's a consultant pulmonologist and critical care specialist from the Healing Tree, Sri Krishna Hospital, Bhaikaka University from Karamsad Anand in Gujarat. Multiple awards, presentations, etc. And his area of interest, very pertinent to today's meeting, is ultrasound in clinical evaluation, medical pleuroscopy. But he's also an intensivist, so other areas of interest are sepsis, extracorporeal therapies, high-risk bronchoscopies in ICU. So he'll, again, bring in a lot of value to the table as we go ahead with the panel discussion today. So if you can stop sharing, and I'll crack on. So a request to our audience, I need to finish the panel, if I can, by 10:15 today. So it'll be great if the answers are short, carry home messages for the audience. People have heard Uma and Nishant speak at length. So crisp, short answers. If you have a question, please just put up the hands up emoticon for us and I'll come to you. And we'll also take questions from the audience as we go along and also at the end. So I'll start off with you, Akhilesh. Dr. Akhilesh, tell us briefly, we've heard from both from Uma and from Nishant about the role of ultrasound, but tell us, as things stand today, what are the common uses of ultrasound for a practitioner like myself who does respiratory medicine on a day-to-day basis, including intensive care? Dr. Akhilesh, please.
Thank you, sir. Thank you, Amita ma'am, and IOB officials for the opportunity and sir for nice introduction. Just before coming to the question, I would like to have a big announcement regarding bronchocon. We have done a very successful bronchocon, that is in Silver Jubilee in Mumbai, and we are looking forward for Kochi bronchocon with all the blessings and support from the all senior faculties and officials from the Indian Association of Bronchology. It will be conducted on May 24, 25 and 26 at Kochi, and we are having around 6 workshops and around 9 areas for abstract submissions. So requesting everyone for their active participation as faculties, delegates, and also promote for all juniors for abstract submission, which is one of the most important category for these courses. So coming to the question, sir, regarding the role of ultrasound in pulmonology, we have heard extensively from Dr. Uma ma'am and Dr. Nishant Sinha. So primarily nowadays we don't usually do a manual aspiration if there is an ultrasound facilities available. It's becoming a norm now. So it helps to identify the site of needle insertion, also to quantify the fluids or any pleural thickening, and these are some of the usual indications for in pleural effusion and also post-procedural complications. We don't need to shift the patient for any CT rooms, and radiation exposure can be avoided. So these are one of the common indications. And second, for procedures like several centers do ultrasound guided Truckered biopsies and FNACs from non-resounding consultations or the peripheral masses also. So that also can cut short the cost and also comfort for the patients. So these are some of the usual indications. Then again, we have heard already about parenchymal disease. In those areas also, ultrasound is will be helpful for identifying consolidation, collapse, and other interstitial diseases. So mainly we can classify as pleural and parenchymal use of ultrasound.
Thank you, Akhilesh. So very nicely explained. Pleural procedures for sure. Consolidation, parenchymal diseases are things which are evolving. I love the long road that Nishant showed a little while ago in trying to explain parenchymal diseases. So I think it's still in evolution. So Uma, you want to add anything to what Akhilesh said as far as indications are concerned? In my practice, it's mainly pleural diseases where I use it. But like I said, I have got a very sort of dormant ultrasound practice. So from an expert, anything else to add, Uma?
Yeah. I very succinctly put. Definitely very, very useful in pleural diseases. A lot of pleural effusions. As I said, we can make out between transudative, exudative effusions, between malignant effusions. Is it just a plain and simple transudative effusion? Not only that, parenchymal diseases, which he said, consolidation, collapse, we can even diagnose pulmonary embolism.
Sure.
We can differentiate between interstitial lung disease versus pulmonary edema. Okay, we can differentiate between ARDS versus pulmonary edema. So if we have, I think even minimal training is enough. The training curve is quite high. A person who's just learned from the workshop, say within 1 or 2 weeks of practice, definitely can be, an expert in making out these diseases. So definitely will be very useful in day-to-day practice.
Sure. So Uma, would it be fair to say for the last 3 indications that you said that, the statutory warnings which come with say, do not try at home, it's only for the expert. Do you think that statutory warning should go up for the last 3 indications you mentioned? Because those are not ones I use on day-to-day basis. I would probably use a CT in those cases.
Yeah? I think, as I said, though the learning curve is steep, you should always, make sure that you are expert enough that you are able to apply these ultrasound for these indications, definitely. But once you are there is no looking back.
So if you adapt it, all the indications that Uma spoke about.
In our hospital, we go around with our ultrasound machine. We can make out all this. So not a problem at all.
Grand. Let me come to you, Dr. Kiran. So, Kiran, what probes should a pulmonologist be familiar with? And why are you mentioning those specific probes and not the others? Was the second part of that question, Kiran?
Thank you, Dr. Raja, for that opportunity. And thank you, Amita ma'am, for putting me on board and giving us faculty an opportunity to be on this platform. I think basically coming to the question, there are three common probes we are adapted to. The curvilinear probe or the 2 to 5 megahertz probe, which is the broad footprint. And then we have the phased array or the echo probe that is commonly used for by the cardiologist. And then we have a linear probe or what we call as a vascular probe, which has a higher frequency of around 7 to 15 megahertz. So the curvilinear probe is commonly used for traditional abdominal and lung ultrasounds. The only problem we face is that if there is a rib crowding or intercostal space crowding, because of the wider diameter, wider size of the probe, it is difficult to see the artifacts through the intercostal space. So in ultrasounds, where you have a limited ultrasound space or an intercostal space, or you want to do a rapid evaluation of the diaphragm, the lungs, as well as the cardiac, we would prefer the cardiac probe. And if you want to do an evaluation of the sliding pleura, the interstitial lung disease, and rule out pulmonary infarctions while doing a Doppler of the lower limbs, you could go for the superficial probe or the linear probe. Hope I answered the question.
Yeah, you did, Kiran. So just sort of for my understanding, if it's looking at superficial structures like the pleura or a vessel, you would go for the linear probe. And for the deeper structures, you could either go between a curvilinear probe and a cardiac probe. Is that sort of the carry home message? Yeah.
Yes.
I have to admit, I almost never use the cardiac probe. It's normally between the linear and the curvilinear probe that I use. But tell us again, I mean, myself and the audience, what exactly would you use the cardiac probe for in the sort of context of thoracic ultrasounds, Kiran?
There's a certain protocols known as the false protocols. For example, you're screening in the emergency department. So you want to find out fluid in the peritoneum. You want to rule out pleural effusion. You want to rule pericardial effusion and rule out pneumothorax. So a rapid screening with the limited time, you could use the echo probe. And if you want to do a detailed examination, especially in the context of thoracoscopy, we would always use the curvilinear probe.
Wonderful. Thank you. Very clear message. Thank you very much, Kiran. Let me welcome Abhishek and get him into the discussion. Abhishek, something which has been said a few times, but worth repeating. Pleural signs. What are the common pleural signs one should know about when they're performing ultrasound? And just the basic ones would do absolutely fine. So, Abhishek, welcome.
Yes, first of all, thanks, sir. Thanks, madam, and thanks, IB, for inviting me here. So, as far as the examination of the pleural signs is concerned, we need to know that Dr. Uma madam and Dr. Nishan just covered it quite nicely in their respective lectures. So, whenever we are doing a pleural ultrasound, so we must be having a clinical examiner, and we must be having some idea that we are finding either for the pneumothorax or pleural effusion or locular effusion. But before that, we need to know. Should be having some basic idea of lung ultrasound. We should know that what are the A lines, what are the B lines, and then how the fluid will appear on the ultrasound. So A lines are basically the horizontal lines, and B lines are the vertical lines. So A lines suggest the normal aeration of the lungs, and B lines suggest a de-aeration of the lung. After knowing this, if we are checking for the pleural effusion, we will have a quad sign, as Uma madam mentioned. Quad sign is when the fluid is of smaller volume, it will be having four borders outlined by the two of the ribs, and inner border will be of the lungs and outer border of the chest wall. Whenever there is a small effusion, then there is a quad sign. It suggests the pleural fluid or anechoic shadow or fluid is inside the lungs, and it is not outside the pleural cavity. So the pleural effusion is confirmed by this quad sign. If effusion is of larger amount, moderate or larger amount, then there will be a sinusoidal signs. So what Uma madam mentioned, in which we have to put a probe in the longitudinal position, and in the fluid we have to enter the M mode. And in M mode, whenever the pleural and the lungs, pleural fluid is in a larger amount, the lung will be floating inside the in the pleural cavity, and there will be a sinusoidal pattern of the lungs which when during inspiration and expiration. What does that suggest? Means the fluid consistency is thin, and we can easily tap this fluid by our needle. If the fluid is of thicker consistency or loculated or septated, then we may not be having this exact sinusoidal signs, and which can suggest that fluid may be having of thicker quality, or and in which we may have to be very cautious while tapping the fluid and at a very specific location. So as far as these pleural effusions are there, this is a quad sign when the fluid is of minimal quantity. When it is with a larger quantity, we will be having a sinusoidal sign. Then another sign, what Dr. Nishan told was Plep's index or Plep sign. In a supine position, whenever the effusion is of larger amount, Plep stands for posterior or lateral alveolar and or pleural syndrome, which suggests that and posteriorly in supine position, if we put the probe, then we can find the length between the our chest wall and the lungs. And if and with this distance, we can have an idea of the quantity of the lungs, how much amount of the fluid is accumulated in the pleural cavity. And it also suggests that it should be less than around 6 centimeter. If this length is around more than 6 centimeter or more than 8 centimeter, then we are definitely not dealing with the effusion. It may be the larger consolidation. So in sometimes we be having a we may need to differentiate it between the pleural effusion or larger consolidation. So in Plep's index, what it suggests, whenever this Plep's index is around 6 to 8 centimeters, up to 6 centimeter, we may have the larger amount of pleural fluid accumulation. But this Plep's index, if it is more than 6 centimeter or if it is more than 8 centimeter, then we are definitely not dealing with the pleural effusion. We are dealing with the larger consolidation. So these are the pleural signs. And
Great.
for pneumothorax, we have in normal pleural in normal lung aeration, we will be having a normal pleural sliding sign. And whenever there is pneumothorax, we will be having a stratosphere sign in M mode. In stratosphere sign means the superficial structure, the skin, soft tissue, muscles will make our barcode type pattern. And the moving lung inside this pleural, beyond this pleura, will make a C sign pattern. It is called a seesaw pattern in normal lung aeration. But whenever there is a pneumothorax, this normal lung aeration will be replaced by the air in the pleural cavity. So we will be having a similar kind of structure in M mode, which we find in skin and soft tissue, which is appearing like a barcode. It will be the barcode sign beyond that point also. So it is called a stratosphere sign or the barcode sign. So whenever we are dealing with this barcode sign and there is absent of pleural line movement, then we are dealing with the pneumothorax. Another sign Madam mentioned was the lung point. So many occasions whenever the lung is partially collapsed, means some part of the lung is in contact with the chest wall and some part of the lung is not in the contact with the chest wall. At this point, we may have the lung point whenever these two borders meet, and this lung point is more than 99% suggestive of the pneumothorax, and it is useful to check the trend of this lung point. If we find this lung point, then pneumothorax is more than 99%. It is confirmed. In rare occasion, when large bully is there beyond this point, we may also find that there is lung point very rarely, but it is possible. So in a clinical evaluation over the time, when we have a pneumothorax, which is a small amount, and we have find the lung point in the very medial location. So means we are dealing with a very small pneumothorax. But over the period of time, because in small pneumothorax, we will be treating this patient only with the oxygen, and we may not be treating directly with the ICD insertion. But at some point, this pneumothorax may be converted into larger pneumothorax or tensor pneumothorax. So we may have to check this over the period of time, and whether this lung point is going beyond some point or not, that we have to check. If it is progressing laterally and towards posteriorly, then this pneumothorax is converted into larger or tensor pneumothorax. And now this is the time we need to treat with the ICD insertion. So these are some of the important signs which we need to check during our pleural examination. These are the important signs.
Grand Abhishek, thank you very, very much. That's very detailed and very comprehensive. So I won't even try to summarize that. I think that was very comprehensive. You've actually answered a lot of the questions that are there in the question box. So Dr. N.P. Bhavyaja had asked, loss of lung sliding means a diagnosis of pneumothorax or not. You've answered that. Implications of identifying lung sliding, you've answered that. And there's a question about how do you distinguish between transudative and exudative effusion ultrasound. You've also answered that. So there's multiple questions that you've answered, even aside from the ones I asked you. So let me go back to Dr. Akhilesh. Dr. Akhilesh, ultrasound in pulmonary parenchymal disease was the topic of Nishant's talk, which I thought he covered beautifully. But maybe some basic carry home messages, 3 carry home messages from the talk, and then I'll quickly ask Nishant to maybe for a one-liner from him. What do you take forward? What do you use lung ultrasound for as far as lung parenchymal diseases are concerned? Dr. Akhilesh.
Yes, sir. We can classify as I told pleural and parenchymal. In parenchymal itself, for consolidation, we know that there is a hepatization stage is there. Most of the time, we can see a dynamic air bronchogram sign in consolidation and a static air bronchogram sign in collapse. So that is one of the main findings for a parenchymal consolidation. Second thing, what we can see is a shut sign. There is a shuttered margin between the normal and the consolidated lung. Can be seen, that's called shut sign, which is seen in again consolidation. And B lanes, though less than 3 B lanes are usually common, more than 3 B lanes can represent some interstitial inflammation starting from interstitial pneumonias, which can be seen sometime in unilateral interstitial pneumonias. We can see in some, especially in atypical organism and all things. So pneumonitis also can be presented with interstitial changes. And also interstitial lung diseases, nowadays there are a lot of articles are coming, and also pulmonary edema. More and more B lanes are more suggestive of diffuse pulmonary edema. So these are the some of the major parenchymal findings which will be able to pick up by ultrasound.
Lovely. So lovely messages, Dr. Akhilesh. I loved the way you picked out the important ones, the ones which are used day to day, and then came to the rarer ones. Nishant, one of the things that I loved in your talk was the way you showed the evolution of your very sick patient with ARDS on ECMO and how things were improving. So that was a prognostic trend that you looked at rather than being diagnostic, which I thought was very useful. So maybe 1 or 2 lines, no more, something to add to what Dr. Akhilesh said, which people can aspire to learn from your talk and going forward in the career for parenchymal disease of the lung? Nishant? Nishant, you're on mute.
For parenchymal lung ultrasound, one thing is very basic and clear. If you are seeing A lines is air, that is normal. If you are seeing B lines is fluid or some interstitial syndrome, that's abnormal. So these 2 things has to be kept in mind, and then you have to move forward. Now, acutely unwell patient, if A line is there, I'm not really worried immediately. But if I'm seeing a lot of B lines, then I think of pulmonary edema, cardiac failure. That's how the decision tree changes immediately from the ER itself, and then we can make decision plans. So I'm not going to look at a random patient lung mass for parenchymal disease. No. So A profile and drip profile is the most important thing. And of course, for prognostication and follow-ups, as I had shown the case, routinely we do ultrasound almost every alternate day for sick patient in the ICU to look for the profiles if the patient is not getting better.
Yeah, so that's, I think, an important message for the audience today. The fact that, of course, you can have a cross-sectional view or one-off view, but what's even much more important for patients in ICU is how is the disease progressing? Are things getting better or worse? Is something that you can do with a bedside ultrasound, which is far more difficult as far as CT scans are concerned. So I think that's an important message. Kiran, I'm coming to you with a very important question. We have spoken about the goods of ultrasound. I think all of us have been very vocal. All of you have been very vocal about what's positive, and most is. But what do you think are the limitations of bedside ultrasound, especially in intensive care, but even otherwise? Kiran.
Yes, sir. Thank you, sir. I think air has traditionally been the barrier for using lung sonology. And I think air in the subcutaneous tissue is by far the most important barrier, I would say,
Sure.
for using a lung ultrasound, because you're not able to see anything in the lung or in the thorax. And then next important thing would be, as Uma Madam was also saying, a proper knowledge of the machine you are using. Whichever machine you are using, the proper usage of the machine, the proper probe to be selected, and the adjustment, at least the basic settings of gain, depth, and zoom would be necessary.
Yeah.
There are certain specific examples, like a central mass. If there is no surrounding acoustic window, for example, there is no pleural effusion, there is no collapsed lung, so that we are not able to visualize the central mass, then it would be impossible to use a lung ultrasound.
Sure.
And specifically in a COPD patient, encysted or a pneumothorax versus a bulla is very difficult. With a large bulla with a pneumothorax in a patient coming to the emergency room, it is almost impossible to use a lung sonology to differentiate
Sure.
the findings. And then small encysted effusion and versus a lung mass, a small mass versus an encysted effusion, it's almost impossible unless you have a contrast enhanced CT thorax. So by far, I think these are the most
Sure.
common things I find as
Yeah.
limitations.
So the first 4 points you made, I think, Kiran, are all under the umbrella of having air there, isn't it? And the fact that air is not a good acoustic medium. The last one I was intrigued by, you spoke about an encysted effusion versus a mass. So educate me a bit more. Why is that a challenge? An small encysted
think,
effusion versus a mass?
Both would be hypoechoic to anechoic. That means they are reasonably black to gray. And you would find a posterior acoustic enhancement, what is known as enhancement of structures beyond the the finding. So small encysted effusion versus a mass would almost look the same, because you would see almost the same findings. So that would be better. You could either put in a needle and aspirate, or you could use the contrast enhanced CT.
Okay. I mean, I wouldn't advise putting a needle in if you're unsure what it is that you're putting a needle into, Kiran. So that's one important point. I think Uma has her hand up. So Uma.
Yeah. I would beg to differ with Dr. Kiran. So even if it is a encysted effusion, the way it looks on the ultrasound image, it will be definitely different from a mass. Mass will almost have like a tissue-like pattern. It will be like a tissue or a soft tissue density. As compared to, you can even make out, you can compare the density of the mass. Say, for example, if it is like a fat density, say if it is a lipoma or something, fat density, you can compare with the chest wall versus an encysted effusion. No, it will be completely anechoic. It will be black. Yes. Even if it is complicated, say it's filled with pus or anything, you can still differentiate whether it is just the tissue, uniform tissue-like pattern, or it is only having specks. So definitely we can make out the difference between an encysted effusion and a mass.
Yes.
Nishant,
thank you.
One line comment, please.
Just wanted to add, so encysted effusion and mass can be picked up if it is touching the pleura.
Sure.
Like the case I showed, lymphoma, that was like a spotter diagnosis. So it is not difficult. It will have heterogeneous ecotexture, and you may have sometimes you see coagulation aqueous sign also. You can put the Doppler there. You will see anechoic area in the mass, but it is not blood. That's called coagulation aqueous. So you can appreciate that actually in the, like you do in the EBUS. So even in the the lymphoma case had coagulation aqueous.
Yeah. So completely agreeing with what you and Nishant, yourself and Uma both said. One of the advantages of your case I thought was the fact that the patient also had a pleural effusion. So you had actually had a window which was better than having air in between, So I think that was one benefit of the case that you explained a little while ago. Quickly come to you, Abhishek, and a brief answer, please, if that's okay. You also have a comment. So your comment first, and then a brief answer. So this is, I think, a controversial question. I'm not sure I agree with what the question is, but I'll put it anyway. In an ICU, if you had a choice between having ultrasound or a chest X-ray, and if someone put a gun to your head and said you're allowed only one, which one would you opt for, and why?
Okay, very big question actually, sir. In today's scenario, first of all, in addition to what the previous speakers told the answer, so one other important limitation of ultrasound is when we check the lung ultrasound, ultrasound has a very good sensitivity and specificity to check the good aeration and de-aeration of the lung pathologies. Means well-aerated means normal lung, and deaerated or deaerated lungs means atelectatic or pulmonary edema, edematous lung, consolidated lungs, and then effusion. The ultrasound has a very, very good sensitivity and specificity regard in these pathologies from well-aerated to deaerated. But it has a very limited sensitivity and specificity to diagnose of hyperinflated or hyperaerated lungs. Means patients having a COPD or asthma, then patient coming with the exacerbation or with the shortness of breath, and we put a probe, and then we see there are A lines only, means lines. We cannot definitely do. We will not definitely differentiate. It is hyperinflated or well.
So Abhishek, we'll move to your question. I think that was something that actually Kiran mentioned, and it comes under the umbrella of there being air, isn't it? So when you talk about hyperinflation, when you talk about cysts, all of that will come under the umbrella of there being lots of air and hence a poor acoustic window. So quickly coming to your question, I'm sorry, I'm hurrying up because we are sort of running out of time, Abhishek. So gun to your head, what would you choose?
Even though, sir, a gun is not on my head, if someone is well oriented to the ultrasound techniques and ultrasound principles, and if someone is there who can use ultrasound, who can evaluate ultrasound principles, then definitely USG must be there in place of X-ray. But in traditional medicine, our teaching, we need to learn here also that ultrasound is not the replacement of our ancient examination pattern like history checking, clinical examination, stethoscope, then X-ray and USG. It should be in that series of the events only, and ultrasound should be in addition to all these findings of the ancillary teachings, and it will to the addition of these findings of these our ancient learnings. It will definitely lead to the confirmatory diagnosis and have a confirmatory therapeutics with that thing.
Great message. Yeah. Go on. Sorry, Abhishek.
And if you are now pertaining to your question, whether we should be having only one thing, why USG should be preferred to XHS? Because USG has having a very high sensitivity and specificity in all lung pathologies like pleural effusion, pneumothorax. It is whether it is pulmonary edema, ARDS, except COPD hyperinflation. It has a very good sensitivity and specificity than XHS. So definitely we will be having a better idea if one is having an idea of using USG. If talk about the ICU patients, main patient can be having can come with the hypoxia, so shortness of breath. He may be having any type of shocks. In that scenario also, we will be having if we having an ultrasound, then we can know much better in today's area. So many things are already recommendation are there of USG use in critically ill patients.
Sure. Great messages, Abhishek. I'm really glad the way you spoke about symptomatology, examination of the patient, chest X-ray, and then ultrasound and maybe CT. I like that algorithm. You made me sound ancient though, because I don't think I can make do without chest X-ray in my ICU or in my ward. I don't think there's one is the replacement for the other, even with a gun on my head. I think they complement each other rather than and give different bits of information rather than one being a replacement for the other. And that was a fault with my question rather than your answer, Abhishek. I think you gave a great answer. So I'll come to you, Uma. So this is a question ideally suited for you. What sort of training, what sort of experience do you think? Tell us sort of numbers. How many supervised? How many should be watched from a distance before someone says, I'm independent, I can go ahead and do chest ultrasound? Uma.
Yeah, well, it's a very good question, actually. We've had a lot of trainees passing through us, and we've conducted a lot of workshops. And so I think I'll be able to give you a fairly good answer about that. So it's how we all started. So you attend some workshop, do some hands-on training, and then, so probably that enthuses you to, learn the ultrasound. Yes, immediately we might not become experts. As you said, probably at least 1 or 2 months of observation and see, it's very easy. It is repeatable. So whatever, or how many ever patients you are, you apply the ultrasound on each and every patient. So that increases your number of, application of ultrasound, and you're able to interpret what you're seeing. So just start off by that. 1 or 2 months of just observation and see whether you're able to identify the effusion, whether it's a transudate, exudate, it's empyema or consolidation, is it pulmonary edema? So just observation. And going on to procedures, ultrasound procedures and this thing, at least minimum 20 to 30 has to be assisted. I mean, you're just, handling the probe, helping the person who's actually doing the procedure, see how they are, because a lot of things go on intuitive, how you are placing the probe, whether you're having the longitudinal approach or how you are directing your needle with your ultrasound probe guidance.
Sure.
So that goes very intuitively. So it takes a bit of time to actually master that technique. So minimum of 20 to 30 where you are assisted, and after that probably you can, supervised 1 or 2 independently you can do. If you are fine, confident about that, and then you can be
Sure.
completely let free.
Great answer, Uma. Thank you. So quickly, we wrote the diagnostic bronchoscopy guidelines a few years ago, and we said something similar. We said 25, which you watch, and you clean scopes, you assist, you sort of hand over the accessories of the bronchoscopy. 25, you do supervised, and then you're good to go. So maybe something similar for ultrasound would also be sort of be similar. So I think that's great. So for people listening in, those are the numbers that you need to be looking at. I'll come to you, Nishant. Thoracoscopy, planned thoracoscopy, elective thoracoscopy. When would you do the ultrasound? Would it be in the suite? Would it be the day you actually planning to do? You plan to do the thoracoscopy? When would you time it? Where would you keep the ultrasound machine? Would it always be in the suite? How do you go about setting it up, Nishant?
Yeah, so basically, if it is an inpatient in the ward and there's a planned thoracoscopy, I would definitely do the ultrasound a day before during my rounds.
Sure.
Then I'll speak to the family about the planned procedure, tell them about the ultrasound finding also 1 day before. But if a patient is coming from home elective, then when I've seen him in the OPD day, that day I'll do it. And I'll do it again on the day of the procedure because I want the machine to be there. So definitely 2 times, one before and one on the day of procedure.
Sure.
To make sure that it is being right and documented.
Yeah.
That's
no,
it.
absolutely, Ishan. So if I'm admitting a patient, I would actually do it in my OPD. We have access to an ultrasound machine, and you turn your patient around, make sure there's enough space with your ultrasound to put in the trocar when you need to put in the trocar. I think that's probably the way that you've described. Absolutely perfect. Let me get in Dr. Akhilesh. So quick answers, Akhilesh. I've got about 5 minutes. So utility of ultrasound post procedures, any procedure, after that you do an ultrasound. How important is it? Is it something that you do on a clinical round post procedure on a regular basis? Dr.
Yes, sir.
Akhilesh.
Yes, sir. First of all, we can just think about pre and post procedures, because as earlier mentioned, if it is having a significant pleural thickening and all, then it will be difficult to undergo sometimes this intercostal drainage, whether to go for a pigtail or whether to plan for a thrombolysis, streptokinase, etc. is important. And even after the procedures, or a surgical intervention is needed, that also we have to plan. We can take the help of an ultrasound. Post procedures, whatever it is, a thoracocentesis or a biopsy or any ultrasound guided Bruker biopsy, whatever, to identify the pneumothorax, the complications like pneumothorax, we always need to do a post procedure ultrasound rather than sending a patient for any chest X-ray, which will be more inconvenience and having a multiple exposure to radiation. So I prefer to do all the patients with these procedures for a post-procedure ultrasound also.
Yeah. I think that's a great message, Dr. Akhilesh. The fact that this is one place maybe where you can actually replace the chest X-ray with ultrasound. I completely agree. Even for a ancient pulmonologist like me, I would actually do an ultrasound here rather than doing a chest X-ray. So well agreed with what you said. Let me come to you, Kiran.
Yes,
What's
sir.
the role of ultrasound in anesthesia for thoracoscopy? So you're putting in your local. Do you use it at all? If you do, in what way do you use it? Kiran.
Frankly, sir, may I confess that I'm not an expert in doing intercostal blocks. I've done a couple of intercostal nerve blocks, which is useful in giving a wide area of analgesia. For example, if you are planning the incision and during the thoracoscopy at the fifth intercostal space, so going one space or two spaces above and two spaces below would give a wide area of analgesia, but it requires expertise and training because when you're doing it in under ultrasound guided, hitting the intercostal space, avoiding the costal groove where the nerves are passing is to be taken as a priority. And there are other blocks like the erector spinae block or the paravertebral block, but I think it has to be the realm of anesthetists who are trained in giving an ultrasound guided blocks. It's not a field that I think we are not to venture. A beginner at least should not venture.
Yeah. So Kiran, I'll tell you something. I'll come to you, Nishant, in a moment. So I have a lot of admiration and time for people who put up their hand and say, this is not something that I have expertise in. You know, I think more of us should be doing that if they don't know about a particular area. But I like the messages you gave. I think they are important. And like ultrasound, I think you can train in giving intercostal nerve blocks too. You know, and when you're a beginner, like you said, you would probably do supervised procedures. You would do it with an anesthetist watching over you. And then as you gain expertise, like in ultrasound, you can probably fly solo and do it. And that's one area where I have trained in. And I've actually learned from my anesthetic colleagues to put in intercostal nerve blocks. Nishant, quick message from you.
Yeah, so exactly the same thing I'm doing now. My assistant is very good. He comes on that day, call him one day before that tomorrow is the procedure. He comes this week and he gives nice erector spinae block. I take videos, I see it. So it works very well actually. So it is a very good nice.
Yeah, wonderful. Let me come to Abhishek. Abhishek, I was just talking about my OPD and the fact that we are fortunate to have an ultrasound in our outpatients department, which we share between 8 consultants. Do you think it's an essential? Do you think this is something we should have, must have, especially for youngsters like yourself? Or do you think having an ultrasound maybe in the intensive care unit and borrowing it to the OPD for short periods of time as and when you need it is better? What would you say? I mean, even from a cost purpose, a lot of us work in corporate hospitals where costs are a major factor. So your thoughts, Abhishek, brief comment, please.
If we are working in a institute, like you are working in the corporates, and then everything, I think that is fine. USG machine can be in the radiology department or in ICU, and then we can borrow them. That is okay. But if we are some pulmonologists having any pulmonologists who are doing any procedure at this place, I think should be having this USG machine in today's era. If you are not going to do any procedure, you are doing only OPD consultation and for any procedure you are going to refer to somewhere else, then it's okay. But if you are doing a procedure at your place, then I think it is mandatory to have this machine now in today's era, because we can have so much of knowledge with this thing. And lung ultrasound or pleural ultrasound, as Uma madam told, it is not very difficult to learn. It has a very slow learning curve. It is under supervision. If you do, I think whatever recommendation we will be saying. But if you do it 2 or 3 times, any signs, if you observe under supervision, anyone can have anyone will be able to do it personally by independently. So I think lung ultrasound, pleural ultrasound is now a need of the hour for our pulmonologist practice.
Agreed, Abhishek. I mean, I completely agree with you. I probably would go one step further. I think we were talking about an ultrasound replacing chest X-ray. I think an ultrasound is now an extension of your stethoscope. You know, if you have an ultrasound in your outpatient chamber, there's a lot of pathologies you can actually diagnose, the consolidation versus the effusion. Is there a lung mass, for instance? All of that you can do on the bedside. And in some cases, you might avoid ending up doing a CT for no reason at all. So I think it's a great tool to have. And even people who are private practitioners should invest in an ultrasound machine before they invest maybe in a bronchoscope, for instance, is my thinking. So come to you, Uma, ultrasound guided pleural biopsy. So maybe a couple of tips. What is essential? What are the precautions that you need to take before you embark? So we're talking about true cut rather than just a pleural aspiration here. What precautions would you tell the beginner about?
Yeah, first I think before delving into the ultrasound guided pleural biopsy is a much more unique and finer aspect of the biopsy. first thing we should gain expertise by doing a large mass biopsy where you're very confident, even if you're going away from the lesion or much deeper, you're not going to create any trouble to the patient. So you learn expertise from that and then move on into the finer pleural biopsy. That is one thing. Another thing is choose your patient properly. So patient selection is very, very important unless you're able to see quite a bit of pleura which is thickened. So first, maybe when we are starting, say 1 centimeter or more than 2 centimeter thickness of the pleura, we are very confident in putting the needle. Yes, that is the way we will start. Later on, once we have gained the expertise, then we can try with much, probably even 0.8 centimeter pleura also.
Yeah.
And choosing the site also is very important. Say right in the anterior and thing, it might be difficult. So the site of the pleural thickness, how much thick, so those will decide.
Yeah. So Uma, one quick message about the vascularity and ultrasound Doppler maybe, you talked about a large tumor and doing a true cut in those individuals, maybe checking for vascularity and avoiding the vessels is another message that, please.
Before putting the needle, we'll just briefly turn on the Doppler so that we know where the vessels are going on. In fact, we had a patient who had come with a large abscess, and we were trying to sample the abscess or just drain from it. So when we put the Doppler, lo behold, we had a pulmonary artery aneurysm. So that much it helped us to avoid the aneurysm and guide the needle. So definitely Doppler will help us to avoid complications. But that is, other than that, we don't use Doppler much in day-to-day practice at least.
Yeah, grand. So it's a bit like EBUS, isn't it? When we use EBUS, when you're sampling, you would actually turn on the probe, the Doppler and see what the flow is like. So it's similar to that. Let me come to you, Nishant.
Very rightly said.
Yeah. So Nishant, quickly, current Indian guidelines, USG in chest practice. I think we have covered everything. But do you think there's one message, if there's one message from the guidelines that you want to, for the Indian practitioners, the ones who are listening to you today, what is that one message, Nishant?
Just NCCP ICS medical thoracoscope guidelines is published 27th of February. I think 2 days, I just read it. And I just read it bit by bit, and that there's one line, before putting the thoracoscopy port, you have to do ultrasound. So at least I got one evidence, we are accepting it, otherwise there's nothing. No other guidelines. This is only one guideline where it's mentioned. Before this, there is no guidelines. So we have this guideline, this is the latest one.
Sure. And that's so useful, Nishant. It's a no-brainer that you use the ultrasound before you put your trocar in or before you put your thoracoscope in. And it's a crying shame that we have not managed to put it into our guidelines. But well said. Thank you. Let me come to...
we have put a long time.
Yeah. Let me come to you, Kiran. I cannot... Kiran...
Yes.
How did you get trained in ultrasound? Let me ask you that. So the question I had was, what are the courses available? I said Uma and St. John's runs a wonderful course, but where did you learn ultrasound and how would you go about learning? I'll come to you in a moment, Uma, but Kiran.
During our DM training, we had 1 month training in the radiology department.
Okay.
So lung sonology, we got an idea during the radiology training there. And then I think Uma Madam conducts a lot of wonderful courses.
Yeah.
So going for these courses, and there are a lot of YouTube videos also, very comprehensive videos, watching those videos. Then I think attending ICU critical care ultrasound courses will also be fine. And then keeping on doing it and learning by experience and confining the biopsies and the needles to a more supervised training would be better, I think.
Yeah.
Thank you, sir.
So tell me something, Kiran. I'll ask you something else before I move on. So you said during your DM training, you went to the ultrasound department and learned from the radiologist.
Yes.
So I'll ask a controversial question. I have found radiologists often being a little averse that you are actually encroaching on their territory. You're trying to do something which they are supposed to have expertise in. So did you find your radiologists welcoming, teaching you, being very proactive, or was there an aversion? Okay, no, this guy is actually coming into my territory and trying to learn something which I'm supposed to do better than the pulmonologist. Was there this element, or were they friendly and welcoming?
I think they've adapted that their area of expertise has been snatched away by gastroenterologists and cardiologists. So I think they've slowly been adapting to the situation. So and I think most of the sonologists are now more welcoming. So I
Grand.
wouldn't think.
Good to hear. Grand.
Thank you.
So Uma, you had a comment, please.
Yeah. Excellently said, Dr. Kiran. I think so. Yeah, that's the way. Usually you start off with workshops and then, get your hands dirty, or we say rather messy, with your ultrasound gel, and then start using it. Definitely it will help. Like he said, a lot of YouTube videos in this thing. There's a wonderful book by Dr. Daniel Lichtenstein, Whole Body Ultrasonography. I think whoever is in the audience, please get hold of that book. It comprehensively, gives an idea of ultrasound, not only in the lung, but the whole body. Mainly importance is given to the lung ultrasound, but whole body, there is this thing. One more message I want to give is we are holding our next ultrasound workshop. It's coming June 20th and 21st. So anybody interested, please register and you will have a wonderful learning experience.
So I'll vouch to that too, Uma, that you guys give people a wonderful experience and wonderful training. So thank you. Quick couple of last questions. I'll come to you, Dr. Akhilesh. Legal documentation, the PCP and NDT rules regarding ultrasound used by a pulmonologist. So can you throw some light? I know this is a difficult area. It's not really within our domain, but tell me some thoughts. Tell me certain things that you know and the audience should know about.
Okay, thank you, sir. Actually, frankly speaking, I had to take a legal opinion before answering this question. Whatever I could get the information is that, first of all, before installing any ultrasound machine in our clinics, we have to have a no objection certificate from a district medical officer of the concerned area. So that is the first thing before installing. And registration ideally should be in the name of a radiologist or a gynecologist. If you are working in a bigger institution, it is not having much issues. Second, a renewal should be there every 5 years. There should be a renewal for every 5 years. We cannot shift the ultrasound machine to somewhere or to someone. We can't shift from one name to some other name without the permission of a district medical officer. And third point is that there should be in the room of ultrasound room, we should document or we should exhibit that this machine is not using for a prenatal checkup. These are the 5 mandatory requirements for this act. Thank you.
So that's a great answer, Dr. Akhilesh. I actually learned quite a bit from what you said. It's time to wrap up. So there's all the questions in the question box, and the entire faculty has actually looked at them. I think have been answered already. There's one question at the end from Dr. Jayaraman, who is always very good, comes up with very difficult questions. He's asked about the Abraham's pleural biopsy and biopsy needle. And I think, Dr. Jayaraman, unless you have one from 20 years ago, it's actually very, very difficult to get the Abraham's needle anymore in any part of the world. So it has to be the good old TrueCut needles now, which come with a guard, and they are good enough. Uma made a very good point when she said that you have to do this with caution, especially when you're dealing with pleura, which is very thin, less than a centimeter in thickness. I would actually be more cautious. I would say go for pleural lesions which are more than 1 centimeter in areas where there is definite pathology. You would be able to tell in ultrasound which portion of the pleura is pathological. Go for that. If you have CT, you could add on the knowledge from your CT when you're doing a TrueCut biopsy, but you need to be cautious in doing them. I'll start off with Abhishek. I want to carry home message, Abhishek, and the message is about what do you think the future holds for you in the use of ultrasound of the lung, of the chest, and what do you think it holds for people? A one-liner, please, from all of you, and I'll come to all of you in turns, starting with you, Abhishek.
Please learn ultrasound. Lung ultrasound, it is easy and useful, and don't be feared of using this probe. How you use the stethoscope, you should start utilizing this probe also.
Love that, Abhishek. Thank you. I'll come to you, Kiran, next. Kiran.
I think learn your basics, know your skills, know your strengths, and keep expanding on whatever you have more to learn. Thank you, sir. Thank you so much.
Thank you. Thank you so
Thank-
much, Kiran. I'll come to you, Akhilesh, next. Akhilesh.
Yeah, learning ultrasound is looks difficult, but it is actually not difficult with a proper supervision or expertise. Expertise guides are there. It is easy to learn. Especially, we need to know a very few signs which is will be required in day-to-day practice. We don't need to do. We don't need to learn each and everything, but for a day-to-day practice, we need to know only very few signs which can easily be picked up by a proper learning and a proper day-to-day clinic. As Madam earlier told, every opportunity or every case, we should try to practice doing ultrasound.
Great message. Thank you. Thank you, Dr. Akhilesh. Nishant, your message.
Yeah, I think I just to second to him, because what I'll say is we should have more wider and frequent application. Do not hesitate to use a machine. It's very simple, and you try to reproduce your own finding repeatedly to check that what we looked earlier, and when you check it again, is it matching and is it overall correlating with the final clinical scenario and diagnosis. Many times, patient already has a CT scan done. You can look back, forward, correlate with the CT scan finding with ultrasound. So a day will come when you will do from front. So CT scan is not required, you are giving the diagnosis. So that's the way forward.
Grand. Wonderful. Thank you, Nishant. And the final message has to be with Dr. Uma Devraj. Uma.
I think all of them have, completely said what I had to say. Definitely, yes. Way forward is, yes, ultrasound is a very, very powerful tool. It's as powerful as, if you see the future, almost your steth is going to get replaced by the ultrasound. I wouldn't say replaced, like I will second your
Complement.
this thing. It is complementary.
Yeah.
Definitely,
Correct.
it is complementary. Yes, it's a powerful tool, but we have to use it very judiciously. We can't be overconfident and say, okay, this is the pneumothorax, I'll put it in a needle. But if there's a non-pneumothorax, we have in fact created one. So that much, we have to be careful. We have to know where we stand. So our expertise level, that thing we have to be aware of. Yes, definitely do practice it every day, gain your knowledge, expand, be inquisitive, and use it every day. Definitely it will be your most dependable friend.
Thank you so much, Uma. And thank you everyone on the panel. So Dr. Akhilesh, Dr. Nishant, Dr. Abhishek, Dr. Kiran, a big thank you to all of you. I learned a lot today, and I don't say that with any modesty. I loved doing the session, even though I stepped in at the last moment. A big thank you to Mehul, and of course, the captain of the ship, Dr. Amita Nene, for organizing this and putting this all together. And a thank you to Cipla for always supporting academic endeavors. And then on behalf of our Kochi team, which is well represented on this panel today, a welcome to BronchoCon 2024 for all of you. We look forward to a mega event, and do participate and make this event a grand success from everyone concerned. And good night, and thank you very much, everyone.
Yeah, thank you.
Good night.
Thank you.
Thank you. Good night.
Thank you.